Welcome to the Family Care Learning Podcast. I'm Scott Hord. I'm the training manager here at the agency, and we are having a special guest here. Chelsea is with us today.
Hello.
And she is in the medical field, and we're going to be talking about substance-exposed infants, caring for substance-exposed infants. And there are a lot of information and details that a person needs to know when they're caring for a child that's been exposed to substances. And so we're going to talk about that. And so Chelsea, I think, why don't you tell us a little bit about what you've done in the medical field and what you're doing right now?
Yeah, so I am old. So I started after I got my Bachelor's of Science in Nursing from GCU in 2007 as a registered nurse, passed my boards, as a pediatric trauma 1 ER nurse in Memphis. From that point, I moved and I worked there for a bit and then transferred up to the NICU special care unit, where we specialized in taking care of babies that were just either they were either still in the hospital from their delivery, or they had gotten sick and needed to come back to the hospital. So it was a varied group of infants that were either just NICU based, really mild and moderate symptoms of all different types of disease processes, basically. And then I transferred and moved back to Phoenix. And I've been in clinical leadership roles out here, both inpatient pediatric care, and then outpatient adult care. And my current role is that I work as a nurse case manager, helping with discharge planning in the inpatient hospital settings at a local pediatric facility here, helping with care coordination, discharge planning, making sure parents, biological foster, whatever, are taught well, so that way they can take care of their child post-discharge from the hospital.
Yeah, that's great. Yeah, and the reason we have Chelsea is because we have developed a course caring for a substance-exposed infant, and we'll talk a little bit about that later. But I wanted to just dive into what are some of the things surrounding caring for a baby that's been substance exposed.
Yeah.
And so you have some experience with the NICU unit, and undoubtedly you've seen a wide variety of situations, whether it be severe or mild in the hospital. And so what can you tell us about the different cases that you have experienced?
Yeah. So in the NICU special care setting, you would have patients dealing with things as, I would say, minor to parents, not minor, but as far as jaundice. So they're in the hospital, they're on Billy lights for a couple of days. We're monitoring their intake and output. And then they go home. Typically, they've got no repercussions from that season of life. In the winter, typically, we've got RSV season and things like that coming up. And we take care of babies that have been substance abused or are born with a wide variety of physical diseases, abnormalities, syndromes. And so I've taken care of a patient in the NICU that was there my entire time there, which was about 2.5 years. And she was there from birth, had never left the hospital, had never been outside. And when I left, she was still there being treated for the long-term care of necrotizing encephalitis and shortcut syndrome, as well as some brain bleed issues. So the range of symptom management can be pretty extensive in those settings.
So they can be in the hospital a very short time or a long time. And you said there's a child still in the hospital.
At that point when I left, so it was 2.5 years. Yeah.
Mm-hmm. And what do some of the mild cases look like for when when they're just there a short time? Yeah,
so those would just be as far as like the symptoms and types of things. Yeah. So Jaundice Care, it could be babies that have been exposed to drugs like we're talking about. It could be just mild symptoms. If it's RSV, that they need some oxygen to help stabilize their respiratory status and monitoring. They might need some medications for that. They could be born with like an STI from their parent that was sent, so they need a couple of days of IV antibiotics, things like that. So it can be a short stint depending on the type of management. And if they get sicker throughout the process, then they might need to stay longer. So we just kind of ebb and flow with whatever is presented.
Exactly. Yeah. Okay. Yep. Well, we're talking about substance exposure that happens to a child, to an infant, pretty much before they're born is the substance that gets, but there's more than just drugs and other things. What are some of give us a little definition of substance exposure?
Yeah, so substance exposure can be different types of illicit or legal drugs. So you might have a birth mom who is dealing with addictions to cocaine or other narcotics or prescription drugs that are illegally taken, or it could be a mom that has problems with alcoholism and that's affecting our fetal alcohol syndrome process, or it could be that it's it would be a mom that's on antidepressants and is followed by her doctor, but they've kept the doses or they decrease the doses, and you're still monitoring for the outcome of that baby post-delivery, because each baby's story is going to be different once they're actually delivered. So it could be that one baby is fine, one baby needs a couple of days of monitoring for things like that. But I would say substance exposure isn't just necessarily illegal drugs. It could be legal drugs, it could be alcohol that you're monitoring, whether or not they received great prenatal care or not, that you're watching for and monitoring. Mm-hmm. So,
and it could be, could it also be other kinds of exposures, like maybe some extreme stress or some kind of toxin that is in?
Yeah, I mean, in the U.S., you see less of the toxin variables, I would say, depending on the, I would say, pre-environment of baby before they're born. Right. I think stress can have an impact. You definitely see moms who are maybe homeless, they're going to have a different outcome and process for their baby. You might struggle more with low birth rate, intrauterine growth restriction processes before they're born. So I would say definitely environment can have an effect on the outcome of that baby's presentation at delivery. And so it's just being wise to know that can affect your child, and to not feel, I know this will sound funny, but there's guilt or shame associated with all these decisions that you've made, right? And so being aware and being honest with the people involved in the care really lets healthcare staff accelerate their response properly.
Yeah, so it really depends on what is self-reported by the mother as far as what kind of exposure that baby's had in the womb. Mm-hmm. And also, so let's talk a little bit about after the baby's born and what happens, what's going on in the hospital, what kind of care, and what happens immediately after the child's born, that postnatal care. That's really where your experience and your expertise has been.
I was not a labor and delivery nurse, bless those people that do labor and delivery.
You didn't have to deliver the baby.
Pregnant women was not my thing, but babies are, so
But after the baby's born, and then how, just a side question, how is it detected, and then what happens right after that?
Yeah, so we... typically, you would hope people would self-disclose what's been taken, and that's not always the case. That's fine. But a baby's going to show the signs, because babies don't lie. They can't. They have no types of guard for that. So when a baby's born, you might see low APGARD ratings, which means that they're not as responsive, or they're not as they might be more blue mottled. They might not be breathing properly. They might not be as responsive. So APGAR ratings are taken for every baby upon delivery, whether or not you know substance abuse was there or not, or substance exposure. From there, you can also test meconium, which is that first fun tarry stool that comes out. That can be tested. Urine can be tested. Blood work is also taken. Yeah. So APGAR tests really are our first pivot. If we don't know about exposure, you can pivot off of the APGAR score, so then kind of go from there. And a baby, like I said, baby's presentation just isn't going to lie, so they're going to be able to figure out if it's substance exposure pretty quickly from that process, from presentation, and then pivot from there as far as the baby's care.
What happens next?
So typically in the hospital, depending on where you're at, they would be transferred to a NICU. Because that's not separate from familial D. And so in that process, they might need oxygen, supplemental with a nasal cannula, maybe a mask, depending on what's happening. They might need to, once you've gone through the process of testing, need to be on medication. So if you're exposed to different drugs, you might need to take morphine to help with that wean process. So doctors, neonatologists, those nurses are trained on the proper medication wean process that should be followed based off of their scores for NAS. So they're going to be scored and observed frequently. When they're observed, this is the hardest process, I would say, for any parent involved. Yeah. When you're in the observation status of this, you're going to be monitoring the baby, and that means no one can touch the baby. So a baby who's presenting with that's going to be very irritable, jittery, and upset, but they need to monitor and see how long symptoms stand for. So sometimes you have to wait a little bit before you can intercede.
That's the difficult part. That's the part
because you see a baby crying and you want to help out. But
that's the part that's probably the most painful to watch, is to see the child suffering. Yeah. And have you seen some situations like that? Or?
Yeah, I remember a patient back in nursing school was my first time I've ever seen a baby that was exposed to drugs, and they were in a very low stimulated area, low lights, and they were just they had a high pitched cry. They were very anxious. shaking, jittery. And so really to monitor those signs and symptoms and then be able to intercede. You are going to be able to cuddle your baby or a staff member will, because we're going to take care of that. But you want to observe for a little bit to see what's going on exactly, to see how they respond without any other stimulus happening in the room. And
so there's an observation period, and that's difficult because the mom wants to hold the baby or the
whoever's there wants to. Nursing staff always hold babies because they feel bad. So
or the nursing staff, from your perspective, wants to hold the baby, but you have to have that observation stage, and then there might be some treatment that might actually require some additional drugs in order to wean that baby off the drugs that they're in a sense addicted to or something.
Basically, when they are growing in the womb, the anything the mom takes, healthy nutrition wise or otherwise, is transferred through that placenta, right? And so that can be alcohol, creates a slow metabolism in babies. Basically, you have a mom who is an adult shape and size, transferring what they're eating and inhaling smoke as well through the placenta into that baby. And a baby is tiny. And so if you can think about it just like that, how much more concentrated and impactful that would be on a baby. And so that's what we're end up monitoring and taking care of from there, which is observing and all of those factors. So it can definitely make a big impact on their life. In the hospital, we also would be doing clustering of care for that baby as well. So we're not gonna just we would cluster the care for checking vital signs, doing medications, doing observations, doing assessments, and then try to cluster periods of time where they can just be still and sleep or just relax, basically.
Yeah, so that's some of the treatment that really there's an observation phase, and then maybe some treatment, and then also tell us a little bit about the kind of postnatal care that should happen, either engaging the potential adoptive mom or the foster parent or the birth mom.
Yeah.
What happens there? What's important?
Okay. Yeah.
Does that make sense?
Yeah. So in the postnatal care period, I should say the observation is not that long. It's not like an extensive one. It's not like 24-hour period. It's just short periods of time. Just to observe the baby for like 10, 15 minutes or more, maybe even less than that, depending on how upset they are, because you want to help them decrease their heart rate.
We
and
don't want
calm.
more trauma.
No. Yeah, because the bodies keep the score, so we don't want to make sure that we help that baby out. In the postnatal phase, like I said, transfer to the NICU. We want to have decreased sensory times, and we're going to have in pediatric facilities, you'll have child life involved that help to teach those families as well how to do comfort positioning, comfort holds for things like that. Yeah. And they're great resources. Child life are some of my favorite people. And then they'll be doing withdrawal scores as well throughout that process. So the hospital staff
taking a score on what the withdrawal levels are.
Yep. Yeah. So that can be, a baby can be in the hospital for 48, 72 hours, maybe a week. It could go 3 to 4 weeks on that substance abuse, a substance exposure process to recover from that. Yeah. They typically want to make sure babies are fully weaned off of medication for 48, 72 hours before they're discharged. So that way we know that they're out of the danger zone for having anything sudden occur. And also I should say that morphine is given for seizures as well. So you're monitoring for seizures, behavior, things like that. Yeah. Our job is to come alongside the family that's involved. Now, family can be whatever family is determined to be. So DCS is involved. They're going to be called if there is exposure risk, and they're going to open a case for us to determine who can be at the bedside and when they can be at the bedside and who can be involved in the care. So it could be, and it's all case by case. And so the range is really wide of what I've seen in my practice. It could be that bio mom, bio dad are allowed at bedsides with supervision. They could not be allowed at all. It could be that foster families are involved, and once they're brought on board, they can be around. And so we work really closely with DCS, and nursing works close with social work to determine those shifts, who can be there, and we follow those guidelines. And so healthcare workers work to treat family. Whatever family is to that baby is now family for us, and that's how we teach and train and support. I think if I could go more about the mom part, but I didn't know. Yeah.
Tell us a little bit more about what you do to help mom, just with self-care, or just being able to really take care of either the mom or the potential foster parent who's seeing this baby and is wanting to hold the baby, but there's that waiting period. Yeah. Is there any kind of self-care that you can recommend for that?
Yeah. So I think one of the toughest spots for a bio parent or a foster parent is because you're not having what you probably expected to be your delivery process, you're going to have some attachment problems. So you might feel guilty that the love isn't there yet, right? But love comes and goes. We know it's an action. And so I encourage, as well as it's just a feeling. So we encourage whoever's involved in that family's care to be present and focus on comfort and basic skills, meeting needs. So those things would be holding the baby, being involved when you're allowed to with feedings, listening to the staff. And then as far as self-care goes, in the hospital setting, what I think is healthy is working with your nursing staff, finding out when you can be involved, feeds, diaper changes, and then knowing when you can leave the room for a little bit, take a break, walk around, go to the cafeteria. I think it's always helpful as whatever parent role is there to let your nursing staff know what you're doing so they know where you are in case they get hold of you.
Okay, those are good.
And then I also think it's really important to journal. So my dad's a counselor, or he's a pastor, and he always tells us to journal. So I say journal your first thoughts, the things that you would tell God if you're religious. Journal your first thoughts, and those can be angry, but no one's going to see them, right? So in the journal, write all of your emotions out, get those out on your paper. I also tell families to keep a notebook or a journal of the questions for the doctors, because when they come in round, you're going to think of questions that are going to drive you crazy that you can't remember, right? And so that's self-care to me, I think, as a parent now, and as helping families at the bedside, that you don't have to constantly have anxiety to remember questions that you want to ask someone when they come around, because it's not an urgent question. I think those things help. I think.
Yeah, and that helps lower your stress level, because you wrote it down, you got it there, you don't have to worry about it. Yeah, and because that is going to be applicable to many of the families we work with who or potential adoptive families, parents who are involved in the baby's life when they're first born, when the child's first born. But then also sometimes like you said, the DCS designates who's going to be the immediate caregiver. Maybe it's a foster parent. So that's great advice that you're saying for all those people. I mean, and then birth mom too. So those are all good, important things. That's good. Now, what about the symptoms and symptom care, things that you're going to observe that a foster adoptive parent or birth mom is going to observe that this baby's experiencing, and then maybe just a little bit about the care related to that. Does that make sense?
Yeah. So I think that in the hospital setting, you're going to see, and at home too, but my brain typically says the hospital setting.
That's okay. That's good. I like that focus because we, like I say, we talk a lot about care at home, and especially in our course. But so I want to make sure we touch this part too, because it's important.
So I think that in the hospital, you're going to see the baby's going to be generally irritable, right? You're going to see fussy crying, high pitched noise. It's a different cry than a typical baby, I would say, that's progressing. And I say typical developing. I'm not trying to say, it's a different high-pitched tone. It can be, a baby might be hypotonic, which means that their arm lengths are kind of limp. They don't bring them into their chest, or they might be very tense. So they might have I'm like positioning funny. So the legs or their back might be stiff and straight because they're trying to deal with that process as well. You might see low birth weights, and so that's going to require initially more frequent checking of their blood sugar levels, because we don't want them to have low blood sugar or high blood sugar. And then what you'll also see is sometimes feeding issues are going to happen. They might not latch on to a nipple when they're feeding well, so that typically requires sometimes lactation consultant for the baby if it's not being breastfed. So I'm having them come in and figure that out. Or really what happened in that situation is a speech pathologist would come up and and do checks in the hospital, and they would be able to so speech in babies is really feeding therapy, and so they work with us on seeing on what a baby can do, for how long they can tolerate feeds. They'll try different nipple types and see what will happen for there. So they're really great resources in the hospital. And then babies get discharged for that for home care. You'll see latch issues. And then poor weight gain is typical of babies that have been exposed to.
What's that?
Poor weight gain. I probably didn't enunciate. So they might not be growing at a trajectory that would be typical for a baby that was born without substances. And so they want to make sure that the baby's on the right type of formula. You can increase the calories in formula depending on the type and brand. And so that's when nutrition is consulted in the hospital. So there's registered dietitians who focus solely on this process and look at weight gain. And Make sure that you don't have too high calorie formula, because that can also cause problems with your GI system. So those are all in the hospital things that you might symptomatically see that are more developmental, I would say. You also might see physical signs. So fetal alcohol syndrome, you might see a smaller head circumference. You might see different facial features, smaller eyes, all these things that can happen.
Right.
And so I think if you have a question about what's going on, that you write it down and ask someone.
Yeah.
Any question is safe in the hospital and should be safe. I would say that
That's good.
a healthcare professional should treat any person that is in the family circle of that patient with respect and honor any question that's asked.
Yeah,
so
that's good. So,
yeah.
Oh, that's so awesome, because to be able to identify those things, and obviously the professionals are looking for all those, and like you say, bringing other resources to help, like you say, whether it be whether the baby's not eating properly or that kind of thing. That's interesting. You mentioned a speech therapist but that's all around the mouth and different things related to that. So I can see that.
Yeah, because they'll look and see.
It's
Sometimes babies have problems with swallowing liquids in certain thinnesses, I would say. So certain types, like water is really thin. Speech therapists can do consults and can do different swallow study tests and can see if baby's tolerating feeds that are taken to a nectar consistency or to like an oatmeal type consistency, something thicker, more viscous than that.
Yeah. So they're going to adjust the formula and that kind of thing. Yeah.
It's all science on the back end for that. But
so exactly. So as you're working with parents and working with the baby, what is an example of something that you experienced that maybe gave you the greatest amount of, passion or concern, and maybe an instant where you experienced that or saw that happen?
Yeah, I worked with different parents and babies who've been substance abused, and or babies that were very young and were abused. And so I think one of the most integral pieces in that is, as a healthcare worker, my job is to give space for them to have their own story before they come into the hospital. And then to be able to meet them where they're at here and to move forward with what we're doing. I took care of a baby that had been abused substances. They were on weaning medications, and sometimes the biological moms don't know where they stand with hospital staff. They feel a little bit distant. And so being able to meet that mom where she's at, and explain what's currently happening, right? It's not my job. Like, I have my own personal struggles that no one sees when I'm at work. And that's my own professional boundary for work. But this mom's coming up and now her life is exposed to all of us. We're a foster family. Now they're trying to enter into this cycle. What do you do? And so I think, my job with this mom particularly is to be aware of what my implicit bias is. So I might have some judgment against her for the choices she's made in her life. I also don't know her whole story. So the thing about help coach her and help her feel confident in what her role is going to be for what I know that day. And so taking it day by day with those moms, explaining that we're taking it day by day, that they might have feelings of frustration, aggression to try to get out of there, sadness and guilt and empathy, and trying to have empathy for where they're at and put myself in their shoes, not to feel sympathy for them, because that's not going to provide the correct resource to them, but to empathize with them, that if I was in your shoes, what would I want? What would I need to be able to move forward? Because, I think that's just really important. So being able to confidently teach a mom how to feed her baby correctly that's 101, right? Because then we have our needs met. We feel like we're connecting. The love might not be there yet, because that just takes time to feel love for your child, whether or not it's biological or foster. But to be able to give that mom confidence that she can feed her baby well, that she can change diapers well.
That's important, because it's because the birth mom's going to feel judged. There's going to feel all these animosity towards her for maybe it's the choices that she made. Or maybe, like you say, sometimes you see babies come back to the hospital who've been abused. And so what you're saying, your role is to really empower that mom to change, to become a better caregiver, a better mom, or a better person, and so you take her history from that day on and forward. And, and that's what we want with our foster adoptive families too, that have connection with birth mom. We want them to see them as an opportunity to help mom to change their course of life.
Yeah. No, yeah.
And provide empathy and provide help and support.
Yep.
And so I think that's really important attitude to have.
Yeah.
When we're looking at working with birth moms. So
Yeah.
so that's some really good stuff. Okay, well, sounds great. Now, any other final resources or things that you could recommend that would help a foster adoptive mom, that family that's going to be caring for this baby that's coming out of the hospital now, and they're getting ready to care for this baby, and maybe they're going to be adopting the baby?
Yeah.
What kind of resources would you recommend for them?
I think if they're in the hospital setting transitioning to home, like I said, to have a notebook and have your questions. Typically, they might have whoever's going to take the baby home from the hospital nest for 24 to 48 hours to do everything at the hospital that they would do at home. But that's with the support of the nursing staff or doctors right on site. And so that's pretty standard. As they're discharging home, resources I think are making sure before you leave the hospital, and if not from your child's pediatrician, that we get intervention in place quickly. And so on the medical front, that's going to be making sure that you follow up with your doctor, that you follow the directions that they're given. That if you have questions, you call your doctor. Don't do social media searches. Bless. If one person you Google something or post something on Facebook, those aren't anyone that can medically be liable for your child. So bless your heart, don't do that.
Yeah, that's good advice.
And then I think PTOT speech, AZIP, all text.
Sure.
You might get all these services that you really need to stick to and ask questions.
Good.
And those are at least the Arizona State resources. And I think leaning in your pediatrician, and if you don't feel comfortable figuring out one that you do feel comfortable with, to ask all your questions and concerns. Have those numbers programmed in your phone. Those are the immediate resources that are connected to your child that you can lean into. Yeah. Your insurance might also have a nurse case manager typically that will call and check in if a child's high needs. So they have that resource to help coordinate benefits and coordinate services. So I always have them lean into that. And then from the hospital discharge, and then from you guys, I think that there are social workers that are going to help get involved.
True.
Yeah. So I think that 0 to 3 is your most integral time that if a child's exposed to drugs, alcohol, that you're going to be able to intervene and change their lives. 0 to 3 is so important. And you can see big strides in the postnatal care when you intervene early and make a difference in that way. And it's huge for a child, right? Because you're creating generational growth if you can intervene early and advocate for the child you're entrusted with to be a great caregiver.
Yeah, that's the part that I hear coming back over and over again is the importance of 0 to 3 to really get after care and really follow the pediatrician and all the other professionals, advice and guidance, and really leaning on your social worker and just really taking the best care you can. It can be a scary thing. Yeah. And so sometimes we freeze and we don't know what to do. Yeah. But there's lots of resources. And one thing that's great about this course that we developed for caring for a substance exposed infant is that we kind of go over some of those things. We go over those resources. We go over the different things that you can expect, how to hold the baby, how to soothe the baby, just some of those things. Yeah. So thank you for joining us today. This has been great. And that course, and if you want to learn more about really diving deeper into some of these details and a little bit more how to care for a baby like that, then we want to encourage you to go to that course and check it out. And we want to thank you for listening today and watching today as you consider caring for a baby who's been exposed to substances. Maybe you're going to adopt that baby or just care for that baby as a foster parent. We really encourage you to check that course. It's going to be online. It's online right now at cfcare.org/learning. And you can go there and take the course. And then we just ask that you would consider making a tax-deductible donation of any amount to help produce these courses, to help develop more and more, and also to support families that are caring for these children. And so that's really good. So anyway, thanks so much for joining us. Thank you for listening to this today to educate yourself and to understand more about this topic. So thanks again, Chelsea.
Thank you.